Okay, let's dive deep. Welcome to the deep dive. Today, we're taking your MSRA revision notes on well, a really important medical condition. And we're aiming to turn them into something crystal clear, high yield, stuff you can actually remember.
Exactly. Think of it like cutting through the noise.
Yeah.
Getting straight to what matters for revision for practice.
We're here to unpack those notes, find the absolutely key facts, and, make them stick. Hopefully in a way that feels more like a chat than just reading a textbook.
Absolutely. The goal is you walk away feeling solid on this, ready for questions.
And the condition under the microscope today.
Gonorrhea.
We're working straight from the MSRA notes provided. That's our guide.
And we'll cover everything they highlight.
Yeah.
So starting with the basics. What is it? How do you catch it?
Yeah.
Who's more likely to get it? What it actually does in the body? What else might look like it?
The differentials.
Yeah, how common it is, the specific signs and symptoms you need to look for.
How we test for it.
How we test, how we manage it, what the outcome's likely to be, and crucially, what happens if it gets missed, the complications.
Okay, sounds like a plan. Let's jump right in then. The core definition. What exactly is gonorrhea?
So first off, you probably know the common name, the clap.
Right.
But medically speaking, it's an STI, a sexually transmitted infection, and it's caused by a specific type of bacteria.
And that bacterium is?
It's Neisseria gonorrhoeae. The notes are pretty clear that this bacteria mainly goes for the mucous membranes,
Okay.
most often the ones in the genital tract.
So a bacterial STI primarily affecting the genitals? Is that the whole picture?
That's the main picture, yeah. But, and this is important, the notes straight away add that it's not just the genitals. It can also infect mucous membranes in the rectum, the throat, and even the eyes.
Okay, that's a really key distinction right from the start. Different places, which must affect symptoms and testing later on.
Absolutely. Knowing those other potential sites, definitely high yield.
Got it. So the culprit is Neisseria gonorrhoeae, hiding out in mucous membranes. How does it get around? Etiology, the cause and spread.
Well, like we said, the cause is the bacteria, and how it spreads overwhelmingly, the notes say it's through sexual contact.
Makes sense.
So vaginal, anal, and oral sex.
Pretty direct. Are there any other ways?
The notes also mention mother-to-newborn transmission during childbirth.
Okay.
It's less common overall, but clinically really significant. It can cause quite severe eye infections in the baby. Ophthalmia neonatorum, it's called?
Right, I've heard of that. So mostly sexual contact, but you need to remember mother to child during birth too, especially for PAPADs. Simple enough. Okay, who's more likely to get it? Risk factors. What do the notes say?
The notes group them quite helpfully, actually. They split them into sort of sexual activity factors, broader health factors, and then environmental ones.
Okay, walk us through the sexual activity risks first. Seems like the obvious place to start.
Yeah, these are probably the ones you'd expect. Unprotected intercourse, obviously, especially with someone who's infected or with multiple partners. Younger age is listed too. And just generally engaging in high-risk sexual behaviors without using condoms consistently.
Right, so basically things that increase your exposure risk.
Right.
Makes sense. What about those health factors? Some of them seemed a bit less direct in the notes.
Yeah, they do. Having a compromised immune system is one, which kind of figures, right? A weaker immune system struggles more.
Sure.
They also list sharing needles or drug paraphernalia.
Sharing needles. I usually link that with things like HIV or Hep C, bloodborne viruses. Why is it a risk factor for gonorrhea?
Yeah, it's an interesting one from the notes. I mean, sexual transmission is definitely the main thing. But including needle sharing, it likely points to, overlapping risk behaviors.
Okay.
People who share needles might also be more likely to engage in other high-risk stuff, like unprotected sex. It just shows how vulnerabilities can kind of cluster. The notes also mention a history of incarceration under health factors.
Incarceration. Why is that a risk factor?
Well, the notes list it. It's probably less about being in prison itself and more about the populations affected. You often find higher rates of STIs in incarcerated populations.
I see.
Plus, maybe limited healthcare access before or during, and potential for unprotected sex within institutions. It kind of points to that bigger picture, the social context affecting health.
That makes sense. It's not just the specific act, but the environment, the systemic stuff. which leads nicely into the environmental factors the notes mention.
Yeah, these are things like living in areas where STIs are just more common, high prevalence, and crucially, having limited access to healthcare or sexual health education.
Right, lack of knowledge or resources.
Exactly. If it's common around you and people don't know how to prevent it or can't easily get tested, well, that environment just keeps the risk going.
Ties it all together. It shows STI prevention isn't only about individual choices, it's about community health too.
Precisely. Limited access is a direct vulnerability.
Okay, so we've got the bacteria, how it spreads, who's more at risk. Now, pathophysiology. How does this bug actually cause disease once it's, inside?
Right. So once Neisseria gonorrhoeae gets onto those mucous membranes, say in the urogenital tract, it basically invades the cells.
Invades them.
Yeah, think of it like setting up shop and, well, causing trouble right away.
Little cellular squatters?
Sort of. And this invasion, it triggers inflammation. Your body reacts.
Yeah.
That inflammation, that's what causes the symptoms we see.
And if you don't kick these invaders out?
Well, the notes really stress this. If it's untreated, the infection doesn't always just stay put. It can spread.
Spread where?
From that initial spot to other parts of the body. And that systemic spread, that's what leads to the more serious, widespread complications down the line.
Okay, so local invasion, inflammation, potential for systemic spread if ignored. That progression's important to get.
It really is. Understanding that potential spread makes you realize why quick diagnosis and treatment are so vital.
Speaking of diagnosis, what else might look like gonorrhea? If someone comes in with symptoms, what else should be on your mind? The differential diagnosis list from the notes.
Yeah, the notes list several conditions that can look pretty similar, which means just going by symptoms alone isn't reliable.
Right.
So things like chlamydia, that's another bacteria, chlamydia trachomatis.
Okay.
Syphilis, caused by Treponema pallidum. Genital herpes, that's viral, HSV. And also sometimes just a straightforward urinary tract infection, a UTI, because some symptoms like pain when peeing overlap.
So mostly other STIs plus UTIs. That list basically screams you have to test specifically, doesn't it? You can't just guess.
Absolutely. Which is why the next bit, investigations, is so critical.
Before we hit testing, let's zoom out for a sec.
Yeah?
How common is gonorrhea, say, in the UK? And who's mainly getting it? The epidemiology bit.
Right. The notes state it's common, and it's a reportable STI in the UK.
Reportable meaning?
Meaning public health bodies track the cases, so we actually have data on how it's spreading.
Okay, and what's the trend according to that data?
The notes are explicit. The incidence is increasing.
Increasing. Okay, it's worried. So it's not some old disease fading away. It's actually a growing issue you're going to encounter.
Exactly. Knowing it's common and increasing makes it a super high-yield topic for exams like the MSRA.
Definitely.
The notes also specify a key demographic. The rise is particularly noticeable among young adults.
Common, increasing, affecting young adults.
Right. Definitely something you need to be on top of. Which brings us to symptoms. What does it actually look like? The clinical presentation. The notes break it down by location. Let's start with the genitals, the classic presentation.
Okay, so in men, the notes describe things like urethral discharge, often quite thick, maybe pus-like.
Okay.
Pain or burning during urination, that's dysuria. And sometimes testicular pain or swelling.
Right, those sound like the symptoms people often associate with STIs. What about in women? In women, it can be a bit different, sometimes less obvious. The notes mention increased vaginal discharge, pain or burning when peeing, abdominal or pelvic pain, and abnormal vaginal bleeding, like bleeding between periods, for example.
That pelvic pain and bleeding in women, that hints at that upward spread we talked about earlier, doesn't it?
It does, and it implies a really crucial point from the notes' detailed list. Symptoms can be much milder or nonspecific or even totally absent, especially in women.
Right, someone could have it and have no clue. What about the other spots, the rectum?
Rectal gonorrhea, yeah. From anal sex, or maybe spread from the genitals. The notes list symptoms like anal discharge, itching, pain, maybe some bleeding, or just discomfort. But again, can be subtle, or nothing at all.
And the throat, from oral sex.
Yes, pharyngeal gonorrhea, infecting the throat. Often has minimal or no symptoms. If there are symptoms, the notes say maybe a sore throat, some redness, inflammation, but often people are completely asymptomatic.
Wow, so a lot of infections could just be silent, especially throat, rectal, and in women. That really hammers home the need for screening, doesn't it? Based on sexual history, maybe? Not just waiting for symptoms? Definitely. Screening high-risk groups is key.
What about the eyes? The note said rare.
Yeah, where in adults, usually from self-inoculation, like getting infected secretions in your eye. The notes say it causes conjunctivitis, redness, discharge, itching, pain. But as we mentioned, it's a much bigger deal in newborns if they get infected during birth.
Okay, so a massive range of presentations, from classic symptoms to totally silent. Given that variation, how do you actually nail the diagnosis investigations?
Right. The gold standard test, the one the notes really highlight, is nucleic acid amplification tests.
NOTs.
NOTs. What are they actually looking for?
They're super sensitive tests. They look for the bacteria's genetic material, its DNA or RNA, Neisseria gonorrhoea's specific signature.
And where do you get the sample for a NOT?
The notes list various options. Urine is common, or swabs from the affected site, urethra, cervix, rectum, throat. Depends on where you suspect the infection is, the patient's gender, their sexual history.
Okay. So if someone has symptoms or you're screening based on risk, NOTs from the right place are the way to go. The notes also mention just swab tests.
Yeah, so swabs are taken from the area and sent off. I mean, traditionally you do culture in the lab, grow the bacteria.
Right.
And culture is still sometimes needed, especially for checking antibiotic resistance. But NOTs are generally preferred now. They're just much more sensitive, can pick up even small amounts of bacteria. The notes really focus on NOTs as the main diagnostic tool.
Got it. NOTs are the key investigation. So you got your confirmed diagnosis. Now what? Management. How do we treat this?
Okay, the core principle is antibiotics. Pretty straightforward. But the notes make it clear that the specific choice of antibiotics, well, that can vary. It's not always the same drug.
Why does it change?
The big reason, according to the notes, is antibiotic resistance. Unfortunately, Neisseria gonorrhoeae is pretty good at developing resistance. It's become resistant to several common antibiotics over the years. So treatment guidelines get updated regularly based on, surveillance data, what's actually working out there in the community right now.
So you have to check the current local guidelines because resistance patterns change.
Exactly. The notes also mention a common approach nowadays, dual therapy.
Using two antibiotics together. Why is that?
The notes say it's often recommended partly to tackle resistance, but also to cover the high chance of co-infection, particularly with chlamydia.
Because they often travel together.
Very often, yeah. So using two drugs means you treat both at the same time. Even if you only tested positive for gonorrhea initially, it's like covering your bases.
That makes sense. Smart approach. What else is crucial for management beyond the pills?
Okay, this is massively important from a public health angle, and the notes highlight it. Partner notification and testing.
Contact tracing, basically. Telling partners.
Yes. Finding and letting recent sexual partners know they've potentially been exposed. That's essential.
All right.
Well, these partners need to get tested and treated too, even if they have no symptoms. It's critical for stopping the infection spreading further in the community, and also it stops the original patient just getting reinfected straight away.
Right. That makes managing STIs about more than just the one person in front of you. It's a community health thing, breaking the chain.
Totally. And one last thing the notes mention is follow-up testing.
Testing again after treatment.
Yeah. For gonorrhea, it's often needed. A repeat test, sometimes called a test of cure, to make absolutely sure the treatment worked and the infection is gone. No lingering bugs, no reinfection.
Okay, so antibiotics,
Right.
Probably dual therapy, check guidelines, trace and test partners, and then retest the patient to confirm cure. Seems thorough.
It needs to be. It's about treating the person and stopping the spread.
So if you do all that, what's the outlook? Prognosis.
Good news here, mostly. The notes say gonorrhea is curable with the right antibiotics.
Great. So it's not something you're stuck with if you get it sorted.
Correct. But there's a big but or caveat in the notes. The risk of reinfection is significant if sexual partners aren't also treated.
Links straight back to partner notification.
Exactly. You get cured, but if your partner still has it, you can just catch it right back again.
Makes sense.
So the overall prognosis message is good for the individual if diagnosed and treated promptly, but stopping reinfection and onward transmission, that relies heavily on those partner notification steps.
And what if it's not caught quickly? Or treatment doesn't work? Or partners aren't treated and reinfection happens? That's where complications come in. The notes listed some serious ones. What are they?
Yeah, these are definitely high yield points, things you really don't want to happen. Untreated gonorrhea can cause major problems. First, especially in women, is pelvic inflammatory disease, PID.
Right. We touched on this with the symptoms. What exactly is PID?
It's when the untreated gonorrhea spreads upwards, from the cervix up into the uterus, the fallopian tubes, the ovaries.
Causes inflammation up there.
Yes, and that can lead to chronic pelvic pain, but maybe even more importantly, long-term. It's a major cause of infertility. And it increases the risk of ectopic pregnancy.
Wow. So untreated gonorrhea can literally stop someone from being able to have children easily or cause a dangerous pregnancy outside the womb. That's severe.
It absolutely is. It's a huge reason why catching and treating gonorrhea, especially in women, is so critical. Another complication, rare but serious, is disseminated gonococcal infection, DGI.
Disseminated, meaning it's spread all over.
Yeah, basically. DGI is when the bacteria get into the bloodstream and travel to other parts of the body far from the original site.
What does that cause?
The notes mention systemic symptoms, fever, joint pain, a typical kind of skin rash, and septic arthritis, which is a nasty infection in a joint.
So the bacteria are floating around in your blood, causing joint infections, skin problems.
Yeah.
That sounds like a much more serious whole-body illness.
It is. And finally, the notes list one more really important complication, increased risk of HIV transmission.
Gonorrhea makes you more likely to get or pass on HIV. Wow, that's a huge connection.
Yeah, the notes explicitly state that. Having gonorrhea increases the risk of both acquiring HIV if you're exposed and transmitting HIV if you already have it.
Why is that?
Well, the notes don't detail the mechanism, but essentially the inflammation and damage gonorrhea causes to the mucous membranes can make it easier for HIV to get in.
Creates entry points.
Exactly. And if someone already has HIV, the inflammation might increase viral shedding, making them more infectious. The key takeaway is that link.
That is vital to remember. It makes treating STIs like gonorrhea part of HIV prevention strategy too. Shows how interconnected sexual health is.
It really does, a powerful reminder of the wider impact.
Well, we've definitely put these MSRA notes on gonorrhea through the deep dive. We've covered the definition, spread, risks, how it works in the body.
What else it looks like, how common it is, and that it's increasing.
The different symptoms depending on the site, how we test for it.
The management antibiotics, crucial partner notification, follow-up testing.
The prognosis good if treated, but risk of reinfection, and those really serious potential complications if it's missed. PID, DBI, and that critical link with HIV risk.
Yeah, we've tried to pull out the absolute key points from each bit, highlighting why they matter for your understanding, your exams, and your practice later on.
Those complications, especially PID, potentially causing infertility, and the HIV link, they really drive home why this isn't just another bug. It's got serious consequences if not managed properly.
And thinking about how common it is, how it's increasing, and how often it can be asymptomatic, it really makes that partner notification piece feel less like admin and more like a vital public health action, doesn't it?
Yeah, breaking those chains of transmission to stop those complications happening to more people. It makes you think, doesn't it? How an infection that can be so subtle, even silent sometimes, can ripple outwards, causing long-term harm to individuals and contributing to bigger public health issues, like making it easier for HIV to spread.
That's a crucial perspective to hold on to.
Well, we really hope this deep dive has helped cement gonorrhea in your mind. Drawing out the high-yield stuff from your revision notes, keep turning these points over.
Absolutely. Active recall, testing yourself, that's what makes it stick.
And remember, if you are looking for more focused MSRA revision resources, loads of materials are available over at Pathophysiology.com.
And for some great free stuff to kickstart your revision or supplement it, definitely check out MSRA.com.
Keep learning. Keep connecting the dots. We'll catch you on the next deep dive.